Good evening, everyone. Thank you for joining us for Queen's Free Speaking of Health lecture series. Some of you might know that February is American Heart Month, and maybe that's why you're here, because tonight we have a heart topic, and we're going to learn about the prevention and treatment of heart attacks in 2017. My name is Lisa Sakia. I'm with the Corporate Communications Department here at Queen's, and on behalf of the Queen's Health Systems, we welcome you all this evening. And it is my privilege to introduce, I'm going to introduce both speakers together. The first speaker for this evening I'd like to introduce you to is Dr. Mahdi Vele Chowdhury, and I'm going to have him stand. Let's give him a warm welcome. He is a non-invasive cardiologist at the Queen's Heart Physician Practice. For medical school, he attended Jefferson Medical College in Philadelphia, Pennsylvania. He did his residency in internal medicine at Emory University in Atlanta, Georgia. That was followed by a fellowship in cardiology at the Stony Brook University in New York. He did a subspecialty fellowship in advanced cardiovascular imaging at Brigham and Women's Hospital in Boston, Massachusetts. He is an assistant clinical professor of medicine at the John A. Burns School of Medicine at the University of Hawaii. In his spare time, he likes to play basketball, and he said nowadays he enjoys simply playing at the beach. Why? Because it's special, because he's playing with his 2-year-old son. That is Dr. Chowdhury. I'd also like to introduce at this time Dr. Jared Oyama. Did I hear a shout over there? Go Dr. Oyama. He was born and raised right here on Oahu. He received his medical degree from the University of Hawaii John A. Burns School of Medicine. He did his residency in internal medicine at the UCLA Medical Center. He also did his fellowship there in cardiovascular disease. He did a fellowship in interventional cardiology at Scripps Clinic, and he specializes in treating blocked arteries and narrowed and leaking heart valves with minimally invasive catheter-based techniques. That is Dr. Oyama. And we're going to begin tonight with Dr. Chowdhury.
Hello, everyone. Thank you for having me. Thank you for the introduction, Lisa. So my part of the talk today, I'm going to talk about coronary artery disease, which means disease of the arteries that supply the muscles of your heart. I'm going to talk about how we make that diagnosis and potentially how we can prevent that from happening down the line. I'm going to get started. This is just a picture of the arteries of your heart that's kind of rotating around over a glass shape of the heart. So when we hear about a heart attack, a lot of times you may hear from your doctors, you may hear the term myocardial infarction or MI. What that means is the myocardium is the muscle of your heart, and infarction means damage or potential injury to those muscles of the heart, so therefore you have a heart attack. And how does that occur? So the arteries of the heart are called the coronary arteries. They're the major blood vessels that supply these muscles of the heart, and over time they can develop blockages. As you can see, blockages are these yellow cholesterol plaques, and if they get severe enough, what could happen is that there may not be enough blood flow getting past these blockages. So imagine if you have a pipe over time can get rusty and develop some crud. This crud in our arteries is actually cholesterol. If you're not getting enough water, or in this case blood, past those blockages, then you're not going to get potentially oxygen and to those muscles. And if you're not getting oxygen, and same thing when you're exercising, you're not getting potentially oxygen to some muscles, you get cramps in, or you can get cramping in the heart muscle. And over time, you can develop injury and then potentially weakness, and sometimes you can have an acute heart attack, meaning all of a sudden it becomes completely blocked. You're not going to get any blood flow past it, and then at that point, that can become life-threatening. So who gets a heart attack? About 1.2 million people in the U.S. will experience an MI or heart attack annually. There's many risk factors we look out for. One is as we get older, like our pipes, our arteries will get older too. So they can develop these blockages just by the process of natural aging. So that's not necessarily anything, that's natural selection, natural aging. That there's only nothing we can prevent with that. But we keep an eye out for that. When people, as you get older, if you have symptoms, men tend to have more heart attacks. If you're a smoker, you can cause damage to these vessels, and you can develop plaques in these vessels more likely. So smokers have higher risk for having heart attacks. If you have high cholesterol, kind of self-explanatory, you get these cholesterol plaques. These plaques are made of cholesterol, so the higher cholesterol burden you have in your body, more likely you'll develop these blockages. Diabetes, that's a big one. Diabetics, we tend to say they're equivalent or they have the same risk of having someone with known heart disease already. Basically, when you have diabetes, you are much higher risk than patients without diabetes for developing these blockages or injury to these blood vessel walls. High blood pressure. Imagine you're putting extra stress on your heart. You're putting extra pressure, so your heart has to pump against much higher pressure. When that happens, you're more likely to develop shear stress or injury to these vessels. So that itself will increase your risk for having a heart attack. Obesity. As we are all, as we gain weight, you're also putting more stress on your heart just by supplying more blood to the rest of your body. But with obesity comes a lot of other risk factors that I mentioned, like diabetes, high cholesterol. So basically, you're setting yourself up for having some other risk factors as well, which will cause injury to the blood vessels that will supply the arteries. And then lack of physical activity. So imagine you are, a lot of times we don't condition ourselves. You haven't ran a block or two in a few weeks, and you start to run again. You're deconditioned. So, and when you are deconditioned, you're putting more stress on your heart. So if you patients that are lacking in physical activity, physical exertion, they're deconditioned their heart in a sense. So when they start to exert themselves, that's going to put at that point some stress on their heart. So those are things that are a risk factor for developing heart attacks. And then, not eating enough fruits and vegetables. And when you have high consumption of red meat, fatty foods, oily foods, basically the cholesterol is, high cholesterol content in all those. Things like fruits and vegetables, we have good antioxidant effects, which will over time decrease the risk of having this injury to the vessels of your heart. So just, dietary habits will sometimes make a big difference. And then alcohol abuse. Again, this is another one that over time will just increase your risk for having damage to the blood vessel walls. So how do heart attacks happen? It happens by, like I mentioned, a process called coronary atherosclerosis. Coronary refers to the arteries of the heart. Atherosclerosis is this process of developing cholesterol plaques. So we build up these plaques, and these plaques are made up of fat, cholesterol, calcium, other substances that will just stick to the blood vessel wall. And this is an example of what it would look like. You see kind of this plaque. This is your blood vessel walls. And then you start to see these plaques that will build up, and you can see that all these red blood cells, this is your blood. As it starts to go past this narrowing, less and less blood will get past it. So that's how, a heart attack will happen. How do we know we could be having a heart attack or we're at risk for having a heart attack? Sometimes people will have symptoms and have a heart attack all of a sudden, but a lot of times people will have sometimes kind of progressive symptoms that you have to keep an eye out for. Classically, we'll get chest pain or chest pressure. Sometimes we'll feel symptoms of some heaviness sitting on our chest. Things like that are red flags we want to raise awareness for. Sometimes we'll notice that you'll have difficulty breathing or shortness of breath. You used to be able to walk a few blocks around Ala Moana, but nowadays you can't. So that's, again, potentially not getting enough blood to those muscles, and you're getting short of breath. Sometimes you can get nauseous. You can get some pain in your abdomen or your belly. So you can get sometimes referred pain. Pain sometimes will go up to your neck or your jaw. And sometimes you get really sweaty. You get really diaphoretic, we say, or just very, very sweaty, because those are some symptoms that when you're having a heart attack, your body is having almost like your fight or flight response, where your body is really worked up and you start to sweat a lot, and those could be the first signs you might be having a heart attack. How do we detect these plaques? Um, you'll always see, and when you go to an ER or your doctor, you'll get these stickers on your chest. It's called electrocardiogram. This is a very simple test. It gives us a lot of information as doctors and providers. It gives us an idea of if you've had damage to your heart in the past, to what your heart rates are. This just basically is a great test to get initially, just to give us a sense of what your heart may be doing. But a lot of times you guys will get stress tests on our patients. I was talking to someone earlier. Basically, we want to sometimes provoke symptoms. We want to see if you're gonna have symptoms with exertion. As you can imagine, when you have these blockages at rest, your blood flow, your body's compensated. You're not necessarily increasing the demand to keep up with the oxygen that your heart muscle needs. But if you start to exert yourself and stress yourself out, like walking on a treadmill faster and faster on a higher incline, you're going to put more demand on your heart. So at that point, we can actually bring out symptoms and we can see changes on our certain tests we can do. So there's many types of stress tests we can do. One is your classic, you walk on a treadmill. We can do it just having the EKG monitoring and the electrocardiogram monitoring. And we can also do things like nuclear stress tests or imaging with nuclear radioisotopes, or we can get echocardiograms. I'll show you some pictures of those in a little bit. Some of us can't walk all that well. We can't necessarily walk on a treadmill. We have pain in our knees. We'll have arthritis. So there's ways we can do a chemical stress test, like a pharmacologic stress test, where we can medically induce simulate stress to your heart and then look for these changes on our imaging tests. So this is, if anyone's had a stress test before, this is an example of, we bring you into our office, we'll hook you up with our electrodes, and then, we're going to check some blood pressure every 2-3 minutes, and we'll keep you on constant monitor. We're going to go up on the speed on the treadmill every few minutes, and you go on an incline. I've done this before. It's much harder than I ever expected it to be. It definitely brings out a sweat in you after a few minutes. And it gives us a lot of information. It lets us know how much you can exert yourself, what your functional capacity is. Say somebody can walk 15 minutes on a treadmill on much, progressively increasing speed. That's a very good prognostic sign that the heart is conditioned well, that if they have blockages, they've compensated internally, that they potentially having an event is very low. So there's a lot of information we get from stress tests. Today we do the stress test, and now you will go under sometimes a nuclear camera called a nuclear imaging test. And I don't expect anyone to really understand what I'm showing you, but basically this is what we're looking at when we do these tests. How we do this is at rest we're going to inject a little bit of radio tracer, and then you'll go on the treadmill, and then we'll inject the radio tracer when you're stressed out. And then we'll look for differences from rest and stress. And if there's potentially areas of the heart that's not getting the radio tracer as stress, we should see that on our images, and that'll give us ideas that in that territory of your heart, you potentially could have a blockage in one of the arteries of the heart. So this is a great test to get done. A lot of times we start with this test with the treadmill in conjunction. It's a safe test. It's non-invasive. We always like to start with some type of safe, non-invasive test first if it's appropriate. So this is one of the ones we do. Another way we can go about it is called a stress echocardiogram, or an ultrasound of the heart. Whoever's seen an ultrasound of babies, it's the exact same thing as they were taking the probe and putting on top of your heart. So what you're looking at here is your heart, and we have 4 chambers of the heart, and then we can look at it in different views. And it's similar concept. We'll get some pictures at rest. We'll have you walk on a treadmill or do a chemical stress test, and then we'll see if there's any difference between stress and rest. If some areas of the heart is not moving as well with exertion, that's an idea that territory could potentially have a blockage, and at that point we have to do much further investigation. One of the newer tests we can do is called a CAT scan, or coronary CT angiography. We can actually take a look inside the arteries of the heart. This isn't a stress test. This is a test like you get a CAT scan of your lungs, of your belly. So only difference is we're taking a picture of your heart. And how we do that is you're going to just lay down on the CAT scan table. You'll get a little bit of injection of IV contrast in your vein. Then after a few seconds, we'll have live pictures of the arteries of your heart. And this is what it looks like. Basically, you'll have this white stuff. This is the contrast, the iodinated contrast. So if you're not allergic to iodine, you can get this test pretty safely if you don't have kidney problems as well. But once you get the test, you'll have this white contrast in the arteries of your heart. And then we look to see where there's not the contrast in that artery. So you see where I'm pointing, all of a sudden, the white becomes black and then becomes white again. So all of a sudden, the contrast disappeared. So when we see that, we call that a blockage. We call that a severe blockage. And this is one of the major arteries of the heart. This is called the left anterior descending. If you ever heard of the widowmaker, if someone has a heart attack of the artery that's the widowmaker, that's the left anterior descending artery of the heart. So we can diagnose blockages that way. And once we see a severe blockage like that, at that point, we'll like, okay, this is very serious. We need to get an invasive test done where we potentially could open this blockage up because they can have a heart attack or if they're not already having a heart attack. So that's one of the ways, those are the ways we can go about making the diagnosis. One of the questions we get is, how do we reduce our risk of having a heart attack? If we have all these risk factors, how do we reduce the risk? First thing is, it is kind of basic. We do have to work on our risk factors. We need to decrease our cholesterol. We need to decrease our blood pressure. We need to have much better control. We need to, if you're smoking, we really need to advocate for, decreasing the amount of cigarettes you smoke to overall, hopefully at the end, you'll stop altogether. If you have diabetes, we need well-controlled diabetes. You can't get rid of diabetes. Our goal is to only control it. And then exercise. As I mentioned, if you exercise, you're conditioning yourself. You're conditioning, your muscles. You're conditioning your heart. So I'm going to go through each risk factor and kind of when you go through your doctors and you're told you have high cholesterol or high blood pressure, what does that really mean, and what does it mean to be treated for it? So if you ever get your cholesterol checked, you see all these different numbers. You get your total cholesterol, LDL, HDL. So our total cholesterol, usually we want less than 200. This measures all the cholesterol particles in your body. And if it's less than 200, good, you're good to go. If as long as you have nothing else going on. Once you get above 200, we start to say, okay, you're a little elevated. Let's see what the breakdown looks like. So if you ever heard about the bad cholesterol, that's called the LDL cholesterol. Ideally, we like to have it less than 130, depending on some other risk factors, which I will go through. But once you get above 130, we start to see you have some elevated cholesterol. Once you're above 190 LDL, you have very high cholesterol. You have to be very, very aggressive to lower it because your risk of having a heart attack, severe blockages causing heart attack or even strokes, things like that is very high. You've heard of your good cholesterol too. We have good cholesterol, we have bad cholesterol, but we also have good cholesterol. The good cholesterol is protective. So you want higher good cholesterol. So once you get above 40 to 60, you're on the right end of the spectrum. Once you're above 60, you're actually protected against heart disease. If your good cholesterol is less than 40, that means you have, less good cholesterol, but likely you have more bad cholesterol to compensate. So what do we do with all that information? And this is available to everybody at home. You just have to go online. They even have an app on iPhones where we basically take those numbers and then in combination with other values like your age, whether you are on medicine already, whether you have high blood pressure, diabetes, we put all that stuff in and then it'll give us a calculation of what your 10-year risk of having heart disease and a cardiac event will be. So once we put in all these numbers, this is called the atherosclerotic cardiovascular disease calculator. Risk calculator is online. This is an AHA, American Heart Association tool. And once your risk is above 5% in 10 years, that's when we start talking to you guys about being on preventive therapy, such as I'll talk about in a little bit, like aspirin or cholesterol-lowering medicines, because you want to reduce that risk. Once you're about 7.5%, we really urge and advocate for aggressive medical management at that point. So I urge everyone to kind of this out for themselves. This is available just to see what your risk is, see what medicines you're on, and then you can have a good informed conversation with your doctor to say, this is my risk, these are the medicines I'm on or I shouldn't be on. This is something that we use in our clinic. This is how I make my decisions of when I decide to put patients on medicine, because you take the whole picture before we decide. You can't just treat one number. We treat all the factors together. One of the newer things we can check is called a calcium score. I mentioned the CAT scan earlier, called the coronary CT angiography. That injects a little bit of iodinated contrast. Another test we can do, we can actually check to see, and this is even less this is no contrast involved. This is just a CAT scan without any, and you don't even need to go in with an IV. You just go to the CAT scan and they'll do a picture, and this will let us know if you have calcium in the arteries of the heart. And actually, and with that information, we can calculate what we call a calcium coronary calcium score. In fact, this value among patients who don't have any known cardiovascular disease, this value is the strongest predictor of having future events, taking into account your age, what your diabetes status is, what your high blood pressure status is. Even if your LDL is if your LDL is more than 190, but your coronary artery calcium score is minimal or 0, your risk for having an event is lower than, say, your LDL value is less than 100, your bad cholesterol less than 100, but your coronary artery calcium score is more than 300. So this is a much stronger value for us to predict events for our patients, and in the newer calculators, you can actually put in these values and give us an updated percentage of what your risk for having an event is. What the calcium score is, basically these cholesterol plaques over time will get calcified. So this crud becomes calcified. So if more crud and more cholesterol you have, more calcium we should see. So this is a really good test. I tend to do this test. A lot of my patients that are not necessarily on medicines, who say have a strong family of history. My mother had a heart attack in her 40s, but right now I'm 50. I'm not on any medicine. I'm wondering what my risk might be. I'll get a calcium score and say your calcium score is really high, but you're not on any medicine. I would really advocate at that point for you to start some preventive medicine to reduce your risk for having premature heart disease. So I think this is something you should potentially talk to your providers or your primary care cardiologist about, if this is something that if you're not on medicine. Sometimes people are on medicine and we check a calcium score, and it shows that the risk for having a heart disease is less than 5%, we'll take them off the medicine because they have absolutely no calcium in their arteries. So it works both ways. So this is something, I think that a lot of the research has gone into this, and this is something that's becoming more and more prevalent. So I talked about cholesterol. I'm going to talk about diabetes just briefly. A lot of diabetics, if you have diabetes, we say patients like diabetes won't have classic chest pain. A lot of times they'll stay asymptomatic or have no symptoms at all, and then they'll have heart attack as their first symptom. So all of a sudden, they're feeling fine, and they'll just come in with an acute heart attack. So if you have diabetes, we really try and talk to you a lot, figure out if you're having any change in your physical activity levels or anything like that, because if you're diabetic, it's tricky to sometimes make these diagnoses. Our goal is to keep your hemoglobin A1C less than 7%. And overall, if you have diabetes, we like to have good control of your blood pressure and cholesterol and all the other risk factors, like having cessation of smoking, to reduce your other risks, because we already know you have a high risk for heart disease if you have diabetes in the first place. Talk about blood pressure. I think some of you guys have got your blood pressure checked out here earlier. It's going to kind of go through what the numbers mean. So you usually given two numbers when you go to the doctor's office. You're given a top number and a bottom number. The top number is our systolic blood pressure, and the bottom number is the diastolic blood pressure. And we go through different stages of what's normal and what's high, what's elevated, and this is just kind of listed. But once you get above 140, you start to have the diagnosis of hypertension. If your top number is more than 140, you have the diagnosis of high blood pressure or hypertension. And if your bottom number is more than 90, then you'll have the diagnosis of high blood pressure or hypertension. So Both numbers are important, and so when you get these checked, it's something. A lot of times, my patients, I'll have them keep a blood pressure log at home, and sometimes they come into my office and their blood pressures are high, but they say at home my blood pressure is always low. Not sure it's because I stress them out or they're just they can't get valet. It's hard. It's stressful coming to our office. But, so it's something I urge everyone to do if you have high blood pressure. I think, it's good to keep a log at home because you'll see a lot of times when you do your normal daily things, you're relaxed, blood pressure is controlled. You don't necessarily need to go up on the medicine every time you go to the doctor because potentially you could have something called white coat hypertension. So these are, but overall, if you do have hypertension, I recommend, you definitely be aggressive with keeping that controlled. Smoking, I think everyone knows smoking isn't good. In fact, the Surgeon General called it the leading preventable cause of disease and deaths in the U.S. Increases our risk for having coronary heart disease or blockage in the arteries of the heart, independent if you have any other risk factors. If you combine it with high blood pressure or high cholesterol, diabetes, that risk increases significantly. Even people who smoke less than 5 cigarettes a day can have early cardiovascular disease. And it actually has a much higher risk in patients that are under 50 than over 50. So just because we're young and we're smoking, our risk for having heart disease down the line and having an event is significantly high. Lastly, I'm going to talk about exercise. So the American Heart Association came out recently with recommendations of what is good exercise regimen. You hear classically it's good to exercise, but what does that mean when your doctor tells you that? So for overall cardiovascular health, we recommend 30 minutes of moderate intensity aerobic activity for at least 5 days per week for a total of 150 minutes. Moderate intensity means like walking a speed of 3 on the treadmill, doing some light jogging, something that basically so imagine 0 through 20, at 20 being the most hard you're working, you're sweating, you're basically thinking, I'm going to poop out after 20. If you're around 12 to 13, 14 in that scale, that's moderate intensity. Or you can do 25 minutes of vigorous intensity. At that point, you're going to be on the scale of around 17 to 18, 18 to 19. So everyone has a different, everybody's scale is different. So whatever gets you to that point, either you do 30 minutes of moderate or 25 minutes of vigorous, at least 3 days a week, that's good for overall cardiovascular health. And they also actually recommend you do moderate to high intensity muscle strengthening activity at least 2 days a week for additional health benefits. So if you have access to a gym or local classes, is something that you can basically do some of these high intensity muscle strengthening activities. We're not saying to go deadlift or things like that, but whatever you can handle. I think everyone has a good gauge of what they can handle. Just want to push yourself. Sometimes get to a point where you can push yourself a little more than you think you can. And then they also have recommendations for lowering blood pressure and cholesterol. So that was for overall cardiovascular health. But what's the level of exercise you want to do to actually lower your blood pressure and your cholesterol? So their recommendations are 40 minutes of moderate to vigorous intensity activity 3 to 4 times a week. So it's similar depending on what goal you're trying to do. Basically, it's saying you want to do a good something regular throughout the week, whatever works for you, whatever activity you like to do. Keep doing that as long as you're consistent with it. All these trials that recommended this, these all go in conjunction with keeping all the risk factors in control. Like if you're smoking, I don't see people necessarily smoking, doing 40 minutes of intense activity 5 days a week. It's just sometimes, they think, so things like that you want to keep everything. You don't just exercise and do everything else that's not good for you. You want to do everything in conjunction. That's kind of one of the takeaways I want you guys to want you guys to understand when you try and reduce your overall risk for heart disease. Lastly, I'm going to talk about medications. So just briefly, what are some common medications you are prescribed by your doctor to reduce your risk for heart disease? One is statins. Everyone's heard of things like Lipitor, Crestor, Zocor. They're all under a family called statin drugs. This reduces the overall cholesterol production in our body. This is one of our main therapeutic options we have medically to reduce your risk for having heart disease, strokes, all that down the line. Also, in certain age groups, in certain patients, we recommend aspirin. Dr. Oyama will go into when he talks about the interventional aspect. Most patients are on aspirin, but to prevent a heart attack, we actually recommend baby aspirin if individuals aged to 50 to 59. And again, not everybody's a good candidate for aspirin. We take into account what their bleeding risk could be. Say somebody has ulcers or things like gastritis, the aspirin might irritate their stomach lining more. So we keep those things in account. You want to always bring that up to your doctor when you see them. If you've had any issues like that about bleeding, especially, because you may not be a good candidate for aspirin in that case. So, but in general, if you're a good candidate for aspirin, it does reduce your risk for having heart disease. One of the newer drugs, and is actually approved now, is called a PCSK9 inhibitor. It's a lot of terms, a lot of letters, but basically it's an injectable form. It's like it's an antibody that we inject, and what it does is actually it binds to the receptors and allows more receptors to capture all that bad cholesterol and clear from the body. And so it's something it's new. It is approved by the FDA, and it has shown that if you're having very difficult time getting your cholesterol lower, even while you're on a good dose of the statin drug, this medicine can reduce that significantly, even up to 60%. So I think that this is something that we're trying to increase the awareness of, the availability of this drug. It's expensive, so I wouldn't start this ever as first line. This is something I would always, I would try other ways to lower your cholesterol first, but this is an option available for some patients. A lot of times people have genetic reasons to have high cholesterol, like they have a genetic syndrome called familial hyperlipidemia, high cholesterol, it's in their genes, so they have really high cholesterol numbers. And so this medicine is very good for that. So I would bring this up with your doctor if you're in that situation. Another drug is called Zetia or Ezetimibe. Basically, it just decreases the cholesterol absorption in your gut. I don't tend to do this ever as first line. I'll start with the statin, but if I'm having difficulty with this one, the statin drugs, this is a good medicine. This isn't going to reduce the production of cholesterol in your body. This will, if you're not eating well and eating the right way, this will help block some of that absorption. But the best way is to eat right. I wouldn't necessarily start a drug if you're not eating right. So I think that's, this isn't a common drug you'll see, because a lot of times dietary control will lower your cholesterol before you ever need other drugs. I think that's it.
Okay, thank you, Dr. Chaudhary. Let's give him a great round of applause. And now we're going to call up Dr. Jared Oyama.
All right, thank you, Madi. So I'm hopefully going to build on some of what Madi talked about and discuss a little bit of the symptoms, but focusing more on diagnosis and treatment of heart attacks and how we handle these in this day and age. So to again review the symptoms of a heart attack, I think we're all familiar with the classic symptom of chest pain or pressure. This is a graphic from the American Heart Association, again reinforcing what Madi mentioned earlier, which is that there are other symptoms that can indicate that you're having heart trouble. So it's important to be aware that it's not just chest pain, but these other things may indicate that you need to be evaluated. Once we have someone with concerning symptoms who comes in for assessment, how do we make the diagnosis? So again, it's important to reinforce that it's not a single test that does this. We have to look at the patient's entire clinical picture, and this includes their history and risk factors, as we've discussed. It includes their symptoms. We also may do tests including the EKG, some blood tests, non-invasive tests, and very often it leads us to a cardiac catheterization, which is what I spend most of my day doing. The EKG is a test that we often start with because it's quick, it's relatively inexpensive, and it's not invasive. It also tells us immediately if someone is having the most life-threatening type of heart attack. It gives us a view of the electrical activity of the heart from different angles, and what we're looking for in particular are changes in certain parts of the EKGs. For instance, if this segment is elevated or depressed compared to normal, as you might be able to see, or if this little wave is inverted, this may indicate that someone is having heart trouble. However, it's also important to know that in many cases, someone with a heart attack may have a normal-looking EKG, so the absence of abnormalities doesn't rule out heart trouble. We often will use blood tests to help figure out what's going on as well, and I'm going to talk about one blood test in particular called the troponin, which is a component of heart muscle. And so if you recall, the heart is largely made of muscle, and that's why you can see these red striations. If we look even closer, microscopically, we see bands of muscle, which are in turn made up of further bands and fibers. And if we look at a molecular level, one of these components is something called a troponin. If someone has heart muscle damage for whatever reason, that troponin, this little protein, can get released into the blood, and we pick up an elevated level in the blood, which may be indicative of heart injury or heart muscle damage. And while it is specific to the heart, it's important to know that it's not specific to a heart attack. So other types of stress to the heart can cause an abnormal blood test, and this is why sometimes it's not entirely clear if someone's problem is a heart artery blockage or some other stress to the heart. Again, this is where taking the entire clinical picture into account is really important. Non-invasive cardiac tests I'm not going to talk about because Madi had mentioned these, and these can include things like an echocardiogram, which is an ultrasound of the heart, CT scan, or stress testing. But very often, in someone who comes in with a heart attack who has EKG abnormalities and blood test abnormalities, this often will lead us to a cardiac catheterization, which again is what I spend my day doing. It is the most definitive test we have for heart blockages because it allows us to look directly at the arteries of the heart. It is an invasive procedure, and so sometimes we don't start with this test, and we want to make sure that we're doing it in someone who can really benefit from it if we're going to subject them to the small but real risk. It allows us to directly look at the arteries of the heart to see if there are blockages there, and it can also allow us a method to intervene upon these blockages. And so it's both a diagnostic and potentially a therapeutic procedure. Cardiac catheterization or angiography is done in a special type of procedure room, and this is actually Cath Lab 4 here at Queens. This is Jody, one of our cardiovascular techs, posing for the picture. But you can see there's a table here in the middle of the room where the patient lies. There's specialized X-ray equipment that allows us to look within the body and to the heart specifically. There are also, around the room, other pieces of very specialized equipment that allow us to monitor different components of the heart and to better evaluate what's going on with the patient, and then potentially to treat them. More important, though, than the equipment is really the team and the people involved. And this is not our cath lab, but when we have a patient in the cath lab, it looks very similar to this. And you can see that the patient's in the middle of the room, and surrounding that patient is an entire team of people working together to get them treated. And this includes techs, this includes nurses, and physicians. What we're doing during a cardiac catheterization or an angiogram is really looking at the arteries of the heart, which you can see lay on the surface of the heart. So how do we get there, and how do we take pictures of these? This really relies on the fact that the arteries of the body are all interconnected. And so when the heart pumps blood out to the body, the blood goes through the aorta, which is the main artery of the entire body. There are branches off the aorta which supply different parts of the body. For instance, these three go to the head and the arms. But the first two arteries that come off of the aorta actually go right back to the heart. And so there's one off to the right and one off to the left. And so the heart, before it feeds anything else in the body, actually feeds itself. Because we know that the arterial tree in the body is all interconnected, we can then take advantage of that to get to the heart. And we can get into this arterial system in a more accessible place, which traditionally has been the groin, right at the crease of the thigh. But more recently, we've been doing this through the wrist, which is a much more comfortable way to do the procedure and a little bit safer. Whichever route we choose, though, we can then follow the arteries all the way back to the heart to gain access to the heart arteries or the coronary arteries. What we see on the outside and what the patient sees at the end of the day is really a small IV puncture. And so here, this is a picture of someone's wrist that has one of these IVs in it. There's a little hub here that allows us to introduce our equipment into the body. But really what's going into the patient is just this little tiny white tube which extends a few centimeters beneath the skin and into the artery. You'll notice there's no incision, there's no stitching needed at the end. It's really just a dot that heals up on its own. People get a Band-Aid at the end of the procedure. The recovery after catheterization is actually pretty remarkable. And one of the reasons that we're moving to doing most of these through the wrist is because it makes the recovery much easier. So this is what a patient looks like immediately after cardiac cath. You can see that he's got a wristband on here because they went through the wrist. And so he doesn't even need to lie down after the procedure. He's able to sit up, watch TV, have a little snack because he's been starving all morning waiting for the procedure. And if you walk through our recovery area, this is really what you see. And we don't have these fancy recliners. Our patients sit on standard hospital gurneys, but otherwise, it's really exactly the same thing. And so whichever route we choose, though, whether it's coming up from the leg to get to the heart, or whether we come down from the arm here to get to the heart, what we do is we advance a small catheter, which is a small tube, directly into the coronary artery. And so you can see here the tip of the catheter sits in the artery. This then allows us to inject a contrast or a dye into the artery directly and take X-ray pictures of that. And we then can make movies of the heart, such as this. And so here you can see a catheter coming around from the leg with its tip in the coronary artery, and the black is the contrast dye that we're injecting into the artery. When the artery fills, you can see the branches that come off of it. You notice that these are nice healthy tubes, nice healthy pipes, and this is what a normal angiogram looks like. If you want to contrast that, this is a patient that I took care of about a year ago who does not have normal arteries. This patient came in with a heart attack, and if you notice here, the artery just stops. So the dye goes into the artery and then all of a sudden stops. This whole area, you'll notice, has no arteries, no dye, and that's because this is a complete blockage of one of the arteries of the heart. And this is what a heart attack looks like when we take someone to the cath lab. This is a patient actually who came in with symptoms of chest pain, collapsed in the ER, and had a cardiac arrest. And fortunately was successfully resuscitated. We then took him to the cath lab, and we were able to restore blood flow to the arteries. If you look here, you notice that same area where there were no blood vessels, where there was no blood flow just a little while ago, now has multiple large branches and blood flow that's been restored to that part of the heart. The procedure took about an hour or so. He was walking the next day and went home a few days later. So it's really a pretty remarkable thing that we can do. And just for comparison, you can see on the left before and on the right after. And so, when people come in, there's no dye here because there's no blood flow going to that part of the artery. Our goal is to restore blood flow to that part of the heart muscle so that it can recover. Sometimes people don't have 100% blockage, but they may have a 90 or 95% blockage, such as this person. And you can see on the left how it looks when they came in, and on the right how it looks after putting a stent in to restore blood flow to that part of the heart. Which brings us to the treatment of heart attacks in this day and age. And so how are we treating people who walk into the emergency department with heart attacks? Of course, I'm going to spend some time talking about angioplasty and stenting, or percutaneous coronary intervention is the other name for it, because that's what I spend my day doing and what I think is really exciting. However, I think it's really important that we point out that that's not actually the most important part of how we treat patients with heart attacks. And really, medications are still the cornerstone of therapy. All patients who come in with a heart attack get treated with medications. And without medication, the other things that we do, such as stents or bypass surgery in some patients, really don't do much. Of course, and so again, all patients get medications. Most of them will end up getting angioplasty or stenting if you come in with a heart attack, and some, if appropriate, will get bypass surgery. I'm, of course, going to focus a little bit more in this middle column because that's what I do and because it's not as fun to show pictures of medications. But when we talk about angioplasty and stenting, just to clarify the terms, angioplasty really refers to using a balloon to stretch open an area of an artery that's blocked. It does not involve leaving anything behind. It just pushes this material out to the side, thereby restoring the inner lumen or the inner part of the tube so that blood can flow. The risk with that, however, is that the material that we push to the side can then recoil and reclose the artery. And so more often than not, almost always these days, we follow that by putting in a stent, which is a scaffold to hold everything open. How do we get that into the artery? Well, just as the catheter allows us to deliver contrast to take pictures of the heart arteries, it also allows us to deliver wires and other equipment into the artery itself. And so we can deliver small balloons like this, and this is how we perform angioplasty, by inserting these small balloons and then inflating them in the area that's blocked. This is what a stent looks like, and you can see here a metal stent that's being held. You'll first notice the size of it. It's actually tiny. These things are only a few millimeters across because that's the size of your heart arteries. These are 2 or 3 millimeter vessels typically. You'll also notice that it's flexible so that it can conform to the twists and turns of the heart artery. When it goes into the body, however, the stent is not in that open configuration, but is actually crimped or compressed onto a deflated balloon like this, which allows it to have a lower crossing profile. We can then insert it into the area that we want, and we inflate the balloon, which then expands the stent into its open configuration, pushes it into the wall of the artery of the heart. We can then deflate the balloon and take that out, which leaves the stent behind. Just another schematic to reinforce that. So we start by placing a little wire across the area that's blocked, and this wire goes from outside where we're working to inside the patient's body and into the actual specific artery that we're treating across the blockage. This then acts as a rail so that we can deliver equipment over this rail all the way into the place that we're treating and then remove it after we're done. So this allows us to put balloons into the artery and perform angioplasty. It allows us to insert stents into the artery and deploy them there to open up and hold open the area that's blocked. And as I said, at the end of it, we remove everything except for the stent itself, which stays behind. This is what it looks like in real life. So this is an angiogram from a few years ago when I was still in training. You can see the catheter coming into the artery, and you can see injection of contrast into this artery. If you notice here, you can see an area of blockage where the artery becomes narrowed. We place a wire across the area that's blocked, and next you'll see the balloon start to come in. So these 2 dots indicate the start and the end of the balloon. We inject a little contrast so that we can see where we're going and position the balloon appropriately. And then we inflate the balloon, which you catch at the end here. We fill the balloon with contrast as well so that we can see it. And so this is what the inflated balloon looks like, pushing open that area that's blocked. We then can put in a stent. This is that crimped stent, just like I showed you a minute ago. And we're again taking a contrast injection to make sure we're in the right spot. We then inflate the balloon, as you can see here, which deploys the stent. And at the end of the day, we take everything out aside from the stent, leaving behind an open artery. And again, just on the left, you can see before, and on the right, after. The stents that we're typically using these days are known as drug-eluting or drug-coated stents, and they consist of a metal scaffold, as you can see, but also microscopic particles of medication, which you can't see. And those medications, when in contact with the artery, get slowly released and prevent the buildup of excess scar tissue within the stent, because that is one of the failure modes of the stent. With the medications, we've drastically reduced the rate of what's called restenosis, which is this excessive scar tissue. And so for most patients, this is the type of stent that we're using these days. We do have a newer type of stent that was recently approved by the FDA and is now available here at Queens, and we're happy to be the first site in the state to offer this, something known as a bioresorbable scaffold, or some people have heard it called a bioabsorbable stent. Instead of being made of metal, you can see that it's made of a kind of clear polymer. This is similar to what absorbable stitches are made out of, and this serves as a scaffold to hold the artery open, but over time dissolves away so that you're not left with anything. On the bottom here, you can see these are pictures taken with a special type of camera that we can actually put into the coronary artery itself. And these are cross sections of the artery. So if we slice it like a loaf of bread, you can see the artery here, and within it, you can see the struts of the stent. After 6 months, the body has grown some tissue to cover it up, and then over the ensuing years, the stent dissolves and leaves nothing behind. And so this is a really exciting technology that's only been recently available here in this country. We are starting to use it here. It's still not as well developed a technology as the metal stent, and so it's not perfect for everyone, but it is a new technology that we have to offer people. I think one of the important points here is that in the past 100 years, it's really amazing what we can do with treating people with heart disease now. 100 years ago, if someone came in with a heart attack, they would get morphine and they'd be put on bed rest for a month. They wouldn't even feed themselves because people were concerned that that exertion would be enough to trigger more heart problems. And these days, we have a whole array of ways to treat people. Again, in the left column, or this middle column, you can see that a lot of that has to do with medications. And really, a lot of the major advances in treatment of heart attack has to do with medications, but it also includes things like stenting, which we talked about, other support devices of the heart, and non-procedural things like cardiac rehabilitation, which plays a really critical role in helping people to get better after a heart attack. And it's important to think about not only the treatment in the hospital, which we often focus about, but how we treat people after they go home. And so this is another graphic from the American Heart Association with 5 ways to reduce your risk of a future heart attack. So how do we treat people after they go home? Again, we see the importance of medications, of following up with your cardiologist, cardiac rehabilitation to get you stronger and build confidence, and then managing risk factors like Madi talked about. So in conclusion, it's important to remember that chest pressure or chest pain is not the only symptom of a heart attack, though it is the classic one, that the diagnosis involves us looking at the entire clinical picture, and that treatment is multifaceted, and we have a lot of treatment options for people in this day and age. Thank you very much.
Thank you, Dr. Yama. And now I'm going to call Dr. Chaudhary and Dr. Yama to take the stage. And we're going to open up the floor to questions. So if you have a question, please raise your hand.
Is it true that plaque in the mouth, on the tongue, in the gums, can travel to the arteries of the heart?
Sorry, can you repeat that one more time? Oh, you heard it?
So the question was whether plaque on the tongue and in the mouth, you said, can travel into the arteries of the heart. Is that correct? So no. The process by which plaque builds up in the arteries is quite different from the process of building up plaque in the mouth. And so they're completely different mechanisms. However, just as a cardiologist in general, we do still recommend good oral health because bad oral hygiene can predispose to infections of the heart, not so much blockages.
Thank you very much for sharing this very interesting information. My question to Dr. Chaudhary is you had one slide up there with the baby or 81 milligram aspirin recommended for ages 50 to 59. What about before 50 and after 59? Why is it not recommended there?
So the recommendation by the society guidelines is for primary prevention. So once, if you don't have the known diagnosis of coronary artery disease, it's indicated the risk in that group is shown that the risk for the benefit from aspirin outweighs the risk from bleeding in that group specifically. However, if the next line below it is that if you're above or below that line, if your risk for we'll calculate your risk for bleeding and then also calculate your benefit from aspirin in other age groups, and if that risk or the benefit risk ratio is in the favor of benefit, then those patients it would be indicated. But usually 50 to 59 in the guidelines for the United States Task Force is what they've shown that most often the benefit always outweighs the risk for primary prevention. But yeah, it's definitely appropriate for elderly over 59, not too elderly, but over 59 and younger. But again, it's not what's actually in the guidelines, so that's why. Yeah, but we calculate the benefit and risk for each patient before we will prescribe that.
Okay,
Great
thank
question.
you. We have a question here.
Who gets the stent and who gets the surgical replacement of the coronary arteries?
So the question is, who gets a stent and who gets heart surgery to relieve the blockages? We look at a number of factors. Typically, the most important one, though, is the number and location of the blockages in the arteries. And so if someone has a large number of different areas involved with heart blockage, that tends to be better treated with surgery rather than stents, particularly in people with diabetes. And so when we've compared people with multiple blockages getting treated with stents and surgery, surgery seems to have an edge, and that tends to be what drives it.
Hi, thank you. What is the longevity of a non-polymer stent, and also what are the side effects or dangers of having one?
Sure. The question is, what is the longevity of you said a non-polymer stent, and what are the side effects? So the stent coating with the medication on it also involves a polymer that allows it to release the medication into the tissue. And I'm not sure if that's what you're referring to. There is a question whether the polymer, which is permanent on traditional drug-coated stents, can cause injury to the artery down the line. And that's still something that's heavily debated. There are newer stents where the polymer, not the metal, but the polymer on top of the metal degrades over time. And the thought is that this may lead to less vascular injury in the long term. But those studies are still ongoing, so we don't know right now. It's an area of ongoing investigation. As far as risks of having a stent, the main two failure modes that we counsel people on are, number one is blood clots forming within the stent, and the biggest risk of that is within the first few months of getting a stent. Typically, that may be related to inadequate thinning of the blood, which allows blood clots to form inside of the stent, which then can cause a heart attack, actually. And the second failure mode is that restenosis, or the excessive scar tissue that I had mentioned. And the restenosis rate, actually, I'll go back to the blood clot, or thrombosis is what it's called. That rate with a modern day stent is less than 1% at a year. It's probably about 0.5% in real world practice. As far as the restenosis or scar tissue, which is a slow and gradual buildup of tissue within the stent, that's about 5% at 2 years with the current generation of stent.
I just wanted to clarify the first question about the longevity, meaning once you put the stent in, how long can it stay there before you have to get another one to replace it?
Sure. So so most patients, if you can get through that first 2 years without a significant issue with the stent, the risk of having an issue beyond that dramatically drops down. It's not zero, but the chance of developing scar tissue after the first 2 years becomes very small. And so for some people, the stent, the one procedure, the one stent is able to last them the rest of their life. In some people, they are develop scar tissue, and then we may need to go back in and reopen things.
Okay, we're going to take 2 more questions. Raise your hand if you have a question.
Do you advocate patients after PCI to be on high dosage of statin, and also indefinite Plavix?
Sure. So the question is, after a PCI or stent procedure, do I advocate people being on a high-dose statin or on Plavix? A high-dose statin or Plavix indefinitely. So for the statin medication, we do recommend not necessarily a high dose, but what's called a high-intensity statin, and that tends to be a few of the medications within that category, because in studies in people with heart disease, these seem to perform better than the less intense statin medications. So these are typically things like Crestor or Lipitor, which we tend to favor over less potent statin medications. As far as the second question, being on Plavix indefinitely after a stent, I don't necessarily recommend that. It really depends on the patient and their risk. And this has something, this is similar to what Madi was talking about with the risk of using aspirin for primary prevention. When we have a patient, we have to look at their risk of bleeding and the risk of a future heart attack. We know that keeping someone on Plavix forever reduces the risk of a heart attack because the blood is a little thinner. However, it increases the risk for having bleeding. And so in someone who's had bleeding, we may not want to do that. In someone who's at low risk for bleeding but has had multiple heart attacks, we may want to leave them on Plavix. And so it's a really individual decision for each patient.
Okay, and our last question here.
Hi, thank you. I had a LAD bypass in 2013 along with ascending aortic aneurysm repair. And reading after that, I have read in several places that these bypasses have a relatively short lifespan, it seems like 5 years sometimes, and they have to redo it? And that sounded kind of scary. So am I off track on that as far as?
Sure. There's different types of bypass grafts people can get. One of the grafts we typically employ, especially for someone with a left anterior descending or LAD disease, is called the left internal mammary artery graft, or the Lima graft. So, and the other types of grafts people can get, you only have one Lima. Everyone only has one left internal mammary artery, but we have lots of vein grafts. We have different veins we can use. People can get saphenous vein grafts to the other blockages of the arteries of the heart. When you have LAD disease, as I mentioned earlier, that's what we call the widowmaker. That supplies the majority of the muscle supply to the muscle of your heart overall. So if we'd like to save the Lima, or the left internal mammary artery graft to that artery, and the expectancy for Lima grafts from studies, and correct me if I'm wrong, Jared, from all the studies that have been done, more than 10, 15 years. Lima longevity, we hope, and the goal is for it to be lifetime. It very unlikely develops blockages in the actual graft. The vein grafts, as you alluded to, the other types of grafts, those longevities are less, because just the characteristic of a vein versus artery, the vein grafts are more prone to potentially get blockages within that. So those potentially, some of the studies are correct, like you said, sometimes 5 to 10 years longevity of the vein grafts. And if that happens, sometimes people, in terms of the treatment options, you don't necessarily have to have another sternotomy. There's nowadays, with all the percutaneous options or intervention, the way the interventional world has advanced, and Dr. Oyama can speak more, but there's options of opening up severe blockages in the native or your arteries that were already blocked. I don't know if you want to mention that.
Yeah, so if you got a Lima to the LAD, assuming the surgeon did a good job at the time of the operation, that's probably going to last you forever. It's very unlikely for that to develop a problem down the line. What you were reading about was probably a vein graft, was about vein grafts. And if you develop a problem with the graft, then, like Madi mentioned, more often what we do, rather than putting someone through a second surgery, which is obviously a big deal, is that we can go in and use stents to open up the artery that's blocked. And that tends to be a lot easier. Easier on you, harder on us. It tends to be harder to open up a blockage after someone's been through surgery, but still doable most of the time.
Okay, let's give Dr. Chaudhary and Dr. Oyama a big hand for sharing their time this evening. And I want to say, we're going to do the CPR kit winners. But I'm going to say a couple things first so you guys don't all run out of here. So hold on, we have 3 winners that were chosen. But before we get to that, I also want to say mahalo to our Queens volunteers, James Liu and Marcy Prinz. If we could give them a round of applause. James is a sophomore, right, at Mid-Pacific Institute, and this is where he chooses to spend his Wednesday night. And Marcy Prinz is also a musical therapist here at Queens, and you might have caught her playing the harp in one of the departments or one of the areas. So we thank you for their help this evening. Also want to thank Pearl Whitaker, who is the manager of Queens Heart, and the staff and the nurses and everyone who is out there providing information, doing the blood pressure screening. So let's give them a round of applause. If you missed them, they have more information out in the lobby. Also, this lecture is being recorded. It's going to be posted on our Queens YouTube channel in 1 to 2 weeks. And for our next lecture in March, it's going to be on bone health. We're going to have 4 specialists. We're going to have a geriatrician, Dr. Britta Aramaki. We're also going to have a physical therapist, Jeremy Angaran. We're going to have Mary Mitsunaga, who is a nurse and a fragilities fractures expert. Also, Dr. Christensen, Kevin Christensen, an orthopedic surgeon. They're going to talk about calcium and vitamin D supplements, bone health, bone density scans, osteoporosis medications, fall prevention tips, and that's March 29th, Wednesday, 5:30 to 7 p.m. You can register online or call our Queens referral line at 691-7117.